That seems like a natural break. All went quiet. Okay, well, I'm going to introduce the next session. I'm Gary Clifford, the Interim Chair of Biomedical Informatics here at Emory. And our next session is High Performance Clinical Informatics. And I'm your moderator for this session, as well as one of the speakers. And I'm going to introduce Dr. Betsy Shankman from Florida University. She is the chairperson of the Department of Health Outcomes and Policy and the co-director for the UF Clinical and Translational Science Institute there. Principal investigator of the Patient-Centered Outcomes Research Institute funded by One Florida Clinical Data Research Network. And her research focuses on determining which combinations of healthcare delivery, community, and patient factors influence quality and outcomes of care, as well as developing corresponding evidence-based strategies to improve health outcomes, particularly for low-income children and families. So thank you for joining us today, Betsy.
Okay, great. Thank you so much. So it's really a pleasure to be here and talk to you about One Florida. This is done in great partnership with our Clinical and Translational Science Institute at the University of Florida. So I really want to start off by giving you a little bit of background about why we developed it and a little bit of the history of it. So our goals when we started thinking about, well, what do we want to accomplish? And certainly part of it, and the theme, of course, has been around big data today and how to use data. But really, when we began thinking about what we wanted to do to continue to move science forward, we wanted to create an enduring infrastructure and capacity for cohort discovery, comparative effectiveness research, pragmatic clinical trials, and also implementation science studies. So we do know that there's a lot of things that work, but we also know that they're not necessarily implemented. And so we wanted to be able to develop the capacity to carry out these different types of studies and identify cohorts in very diverse settings. And we ultimately hope that this would feed into a concept of a learning health system, both within our own local UF healthcare, but also throughout the state of Florida, and do it through a process of stakeholder engagement with people, clinicians, health systems, payers, and industry. And as a way of a little bit of history, One Florida started in 2010 in a very beginning concept with a supplement from the NIH to our Clinical and Translational Science Institute. And Dave Nelson and I got that award, and we began the development. And it continued to increase through the years with different funding. And then Bill Hogan joined us, who's the director of our biomedical informatics program. We continued to receive awards, and then we got the PCORI Clinical Data Research Network, and really kind of just kept developing from there. And I'll talk a little bit about partnerships that we have just begun to establish with Emory and Morehouse that we're very excited about. So who are our partners? Well, you can see here a map of the state, and this all began, as I mentioned, in 2010. The initial partnership was with Florida State University, and you'll notice a lot of these garnet dots throughout the map, and these garnet dots represent practice sites where medical students at Florida State University in Tallahassee, Florida, go for their clinical training. Well, we did not have, that kind of broad reach throughout the state. For our clinical networks, we're located more in the north central part at the University of Florida. So that was the initial partnership. And then we began adding partners. University of Miami came on board with a variety of grant funding. We have clinical partners at Orlando Health and Florida Hospital, Bond, Well Florida Council, which is a series of rural health clinics, and then also Health Choice Network, which is a group of federally qualified health centers throughout the state. And so we formed these partnerships, but then we also began planning, and we recently signed a data use agreement with Emory and Morehouse. And that was really important to us because we wanted to extend our collaborations with clinical and translational science institutes. And you'll notice running across the bottom of the slide, you will see 10 million patients, 4,100 physician providers, 1,200 practices, 22 hospitals, and 67 counties. So that represents the participants in our network. And the participants include giving us information from electronic health records. And so in this slide, you will see the demographic characteristics. This slide is about 6 months old. It was done on about 4.2 million patients. There are more in the network. Just a couple things to point out. Your first column you see is one Florida, then you see the state of Florida as a whole, and then you see compared to the United States. And so we have a fair amount of racial and ethnic diversity. We tend to have, now I am not sure why it's doing that. I am not touching anything. But anyhow, we have a fair amount of racial and ethnic diversity. We have 19% Black or African American, about 60% white. You'll notice that we have a smaller percentage of Hispanics, but again, we've continued to expand, and this slide is several months old. So we are actually up higher and around the 15 to 16% range of Hispanics in our database right now. I just want to say something briefly about patient health status. We use a variety of software. These patients were grouped using data that we have in the One Florida Data Trust, which is a key component of One Florida, and I'll talk about it in a minute. But we have a lot of software that we use to take diagnostic information and group patients into health status categories using diagnostic codes, place of service codes, and other information. And this is from 3M. It is a software program that does the grouping. And about 60% of our patients have what we would call routine healthcare needs. And this was done again on the 4.2 million patients using calendar year 2016. About 60% have routine healthcare needs, but then you can see where they fall on a distribution ranging from mild chronic conditions all the way up to catastrophic conditions. So that's just to give you a little bit of background on the demographics and also the health status. So at the heart of One Florida, so remember we wanted this infrastructure so that we could really begin to use the data and work with the data, but translate it into pragmatic clinical trials and real world settings. But at the heart of it is what we call the One Florida Data Trust. And this is a key component for most of our work. And this is really just a model here showing you how we bring things into the data trust and then what we have to do to access the data. So when you look, you'll see that we have Florida Medicaid and Medicare data. We have that through data use agreements with the Agency for Healthcare Administration in Florida. We have vital statistics information and census tract information. We also receive limited data sets from each of our clinical partners. So those were all the dots on the map. From the majority of those sites, we receive electronic health record data from 2012 going forward, and it's refreshed on a quarterly to monthly basis. As studies are done in the network, we also have study data that goes in, patient consents for registry, or study participation and other types of data collection. So this is all transferred centrally into our data trust, and this was no small feat. It took a lot of building of relationships throughout the state. It took a lot of work with data use agreements and other things that had to be put in place. So it really, I think, was quite a testimony to our partners for everybody to be willing to work together to do this. So they come to us in the form of HIPAA-limited data sets, but of course, remember I said we wanted to be able to do cohort discovery. So we are able to re-identify these patients using an honest broker system. So at each one of our clinical partners, there is an honest broker. And for investigators, they can query the data mart, determine if there are enough patients or settings of a type that they need for their study. And if the query yields something that's positive, you know, if they want to do a study around children with certain rare diseases or pregnant women who smoke or whatever the topic may be, hypertension, then they can query if they find that they have enough individuals to do the study. We have a One Florida IRB, so all of our partners agreed to work with a single IRB structure. And then we have a steering committee. So on our steering committee, each of the partners has representation. And so to conduct a study, you need IRB approval, you need approval from the steering committee. And then once it's approved, then you can go back and work with the local sites and the honest brokers and re-identify these patients for contact, and data are provided. So it's really been, I think, a really good process of how this was set up, and the centralized process has really allowed us to have, I think, better quality control over the data. So you heard me mention that we have one of the Clinical Data Research Network sites. There's 13 of them. You may wonder, well, what's going to happen with PCORI? Some subset of these sites will continue into what they're calling PCORnet 2.0. And that transition process is occurring now. But we did use the PCORI Common Data Model, and this just is showing you the current data elements. It's a really rich data source. It's a combination of claims data that we have, electronic health record data. As I mentioned, we've also linked it to census tract data to provide contextual variables. But there are limitations to this. It doesn't have everything that we need. So we have worked with all of our health systems to give us additional lab information, give us things like head circumference for children, information on what was present on admission when patients come in. So it is extremely valuable, and we continue to add to it with a lot of support from our partners. We have very useful pharmacy information, and Rhonda Cooper-Dehoff from our College of Pharmacy is here, and I'm going to use one of her computable phenotype examples, which you heard about this morning. You heard about the importance of computable phenotypes. So I'll give you an example from One Florida. So this was in January of 2017. We had 4.5 years of data. This is just to give you some idea about, at that point in time, there were 10.6 million patients. We are now up to data on 14 million patients as of July. So we have really been rapidly increasing in our acquisition of data and people added in. You can see the numbers of encounters, diagnoses, procedures, medications dispensed. We also have prescribing information, and we didn't list every variable on here, but an array of laboratory information as well. So I mentioned some of our ongoing activity because really we want this to be a resource, and we're hoping, again, this will be a resource and an infrastructure that will allow us to collaborate as well. But we are adding in additional lab values. There are some basic set of lab values that were included in the common data model, but we're missing some important labs like platelets, for example, that might be very useful for studies. Present on admission variables are very important if you want to look at complications during hospital stays, and a range of other clinical variables that are important, for example, developmental screening measures and others. We recently added adult Medicaid data, and we are in the process of adding Medicare claims data. We also have a partnership with our Department of Health, and we are working with our Florida Cancer Data System, and we're adding registry data from the FCDS. We also are working with our local health systems that are part of One Florida to give us tumor registry data at the same time that they submit it to the state. That way we can work with it more rapidly than waiting for the state to process it. And the enriched environment of having tumor registry data along with all the other factors that are happening to the patients is very valuable. We also have a variety of projects going on around data linkage. One of them is linking Medicaid data to electronic health record data to have a more complete clinical picture of individuals in Medicaid and also Medicare. We have the data linkage project going on with the EHR data with our Florida Cancer Data System. And also we have a project going on to deal with identity resolution so that we are sure that we are really properly tracking and deduplicating the patients. So data linkage is also a big component of what goes on, and there's a series of algorithms that Bill Hogan and his team are using and working on in that regard. So how do I access the data? I'm putting this series in here because, again, our hope is as we continue to move forward with our collaborations throughout Florida and also nationally, we collaborate with many of the other clinical data research network sites throughout the country, that we can enhance our collaborations in the southern U.S. Where we have, as you saw earlier from some of the CDC maps, some of the greatest issues with disease burden and some of the greatest issues with mortality. So in terms of developing a query, we'll talk about computable phenotypes in a minute, but right now we do have what we call query coordinators, and they are programmers as well as research coordinators that work with people to develop the query and to submit it to the data trust. We are in the process of working through putting I2B2 in the One Florida Data Trust so that it will be possible then, just like with your integrated data repositories, to go in and do a query on your own, at least at a relatively straightforward level. Some more complex queries you might probably still continue to need a programmer. This is a slide just showing the self-service query capability that we'll be implementing in 2017. I think a lot of you are very familiar with this because of the I2B2 software, and you're probably very used to what this would look like, but it would just be a very nice menu-driven option for you to get to look at various combinations of the data. In terms of cohort discovery and actually getting data sets, I talked about the process of approval. Requires one Florida IRB and one Florida Steering Committee approval. But also there's a form to what we call our front door. And this front door, you can fill out a form to be able to do the cohort discovery. And then once there is approval, then we provide data sets for these studies. So the making of a query. So I'm going to use the hypertension example, and like I said, Dr. Cooper Dehoff is the expert, but we had a very early collaboration with a group focused on cardiovascular disease within the Clinical Data Research Network sites, and some of that really centered around resistant hypertension. And so when you're thinking about these computable phenotypes, as one of the earlier speakers talked about, it's really important to be very precise. And what do you mean? How do you want to measure it? And then this allows other people to be able to replicate what you did. And you want to know, well, what information should I use? So I listed, a couple different types of hypertension. And then the question is, well, how then do we go about doing that? Do we use ICD-9 codes or ICD-10 codes? Do we use their blood pressure? We have systolic and diastolic values in the data system. Do we use inpatient information, outpatient information, or both? What about the drugs they're on? So the example here of resistant hypertension, here's the definition that was developed here. And it was looking at drug exposure. It was also looking at the blood pressure and the number of drugs that they were required to be on and how many times they had to meet that criteria. So this was a definition that was used to develop the computable phenotype. It was developed in collaboration with UCSF and then tested at some of the other clinical data research network sites throughout the United States. So this really now provides a beginning library. Obviously, there are national libraries of computable phenotypes, but we can continue to add and contribute to that. And that's an important part of our focus in One Florida. So I want to mention some of the studies that we have underway within One Florida. So you can have some examples of what's being done and how it's being done, and then some that we hope will be funded in the future and they're under consideration for funding. So we have a series of what we're calling health system demonstration projects. These are all funded by PCORI, and they're focused on developing predictive algorithms for adverse events within inpatient, outpatient settings, like potentially preventable admissions and readmissions. But of course, they also fall into the category of the earlier talk, where you have to very carefully look at cause and associations and so on. A lot of these algorithms are incorporating social determinants of health, which we know have a very big influence on outcomes of care for individuals. So there is a great emphasis in trying to incorporate neighborhood level information about the characteristics where people live. We also have a pediatric safety study going on around sickle cell disease and care in inpatient settings. In terms of heart health, Rhonda Cooper-Dehoff has a study around more appropriate prescribing of medications for blood pressure management among African Americans. We also are participating in a national study that's being run through PCORI on looking at the proper dosing of aspirin for individuals at risk for heart disease. We are involved in a comparative effectiveness study around influenza vaccine for individuals with heart failure. And then recently there was a study funded around ischemic heart disease in women that is a pragmatic clinical trial that is being led by Carl Pepin at Florida, and it was funded by the Department of Defense. We have a quality of care project funded by the Agency for Healthcare Research and Quality, linking claims data to electronic health record data to look at quality of care for children receiving antipsychotics. And then we have a series of studies around cancer prevention where we leveraged, particularly on the HPV vaccine study, where we leveraged the data trust for cohort discovery, but also we're feeding immunization registry data, electronic health record information at point of care to physicians to improve uptake of HPV vaccine, and at the same time sending messaging, text messages to parents and adolescents around the HPV vaccine. And then there are a couple of different studies going on around tobacco that leverage the data trust. So just to quickly move on to the ones that are under development right now, we have worked closely with Emory and Morehouse and the University of Miami Clinical and Translational Science Institute to submit an application to the Precision Medicine Initiative. It's called the Southeastern Enrollment Center. And we have had a lot of positive feedback, so we will collectively ask you to keep your fingers crossed on that one. Miami would be the lead institution, but we'd all be working together as partners on this, and it would also leverage the data trust. And then there are a series of other initiatives that are being developed. I gave some examples here around comparative effectiveness research around sickle cell disease and quality of care, and different interactive tools that we're developing in collaboration with our College of Engineering. And also the idea around training. There are opportunities around training and using big data related to implementation science and pragmatic clinical trials, as well as many opportunities around cancer prevention. So these are some things that we are looking forward to continuing to develop and work on, and hopefully also receive positive news about their funding. So with that, I will stop and thank you very much and see if there's any questions.
So my question is maybe just one more question about background. So what was the inception of this? Was this something that you or someone at Florida thought was an important part to take on, and it was an institutional approach, or was this more of a research question that came up? This is a relatively heavy lift of all you're describing. So
yes, it was a very heavy lift. Yeah, thank you. It was a very heavy lift. Really, the way it came about was we were really looking at our clinical infrastructure. We were saying, okay, we have this great clinical infrastructure at the University of Florida. We are in the middle of this really amazing rural catchment area, which again is very much part of where you see all the red hot spots from the CDC maps. But nonetheless, we thought, okay, this is great, but we really want to expand our opportunities to look at diverse patient populations and conduct studies in diverse clinical settings. And so we thought, hey, let's meet with the people at Florida State. They have this distributed network throughout the state where they train their medical students. They have all these clinical sites, and maybe we can form a partnership that would allow us then to think about, well, how does this compare in urban and rural settings? How does it compare for Hispanic populations? I mean, we're very interested in pragmatic clinical trials and the component of the CTSA of how do you translate this into the community. I mean, that's really what drove us. And that was our initial impetus, and we were happy with it. But frankly, grant reviewers weren't. When grant reviewers read proposals coming out of Florida, they think, well, wait a minute, you don't have anybody from South Florida. Where's Miami? And so the partnership in part grew also from feedback. So as we continued to develop the partnership, it was like, okay, bring on Miami. And then it just continued to grow and develop. And as we went along, people actually started contacting us, like Miami Children's contacted us and said, hey, we want to be part of this. And everybody really believed in the vision and worked together. So yes, it was a heavy lift, but we had a really incredibly committed group of people too. And like I said, we have a partnership too with Emory and Morehouse and to add to the commitment. So it's been great.
I think we have a question over there, Betsy.
Hi, very much enjoyed your talk. Where did the initial funding come from, and how do you continue to fund such a large project?
Yeah, so the initial funding came from the supplement that was given to our Clinical and Translational Science Institute, and certainly that was not luxurious funding, but it helped us get started. We do have a component of this built into our CTSA that provides some funding for it. Also, we have funding from our James and Esther King Biomedical Research Program, which is basically Florida's tobacco funds. We have funding through PCORI that that again, there's a transition work going on where that funding is expected to continue over the next few years for some subset of our clinical data research networks. So hopefully we'll be in that cohort, but that's yet to be determined. And then we have grant funding. So we set up, as part of this, an auxiliary accounts so that we have cost recovery that now comes into the network through the grants. So it does take multiple pots of funding to keep the momentum moving forward. But certainly our Clinical and Translational Science Institute, it could not have been done without that partnership.
Betsy, I've got lots of questions to ask you, but luckily I can buttonhole you afterwards. We have to move on to the next speaker, so I wanted to thank you again for coming all the way up here and giving us a great talk. Okay, so our next speaker is Dr. Jim Blunt. He's the Chief of Anesthesiology at the Atlanta VA Medical Center and the Chief of Critical Care Anesthesiology for Emory University, and also the Vice Chair for Clinical Research in the Department of Biomedical Informatics. So did you get that in time? That was too fast for you, wasn't it, Jim? All right, thank you.
All right, so it's a privilege to be here today to talk to you about some exciting things that we have going on at Emory. And in the next roughly 25 minutes, what I hope to tell you is about our acute care informatics opportunities and challenges that I sort of see for us as a nation and much of us in sort of the modern world. So here's a list of my disclosures. In full disclosure, I am conflicted in this domain as I am a consultant and equity holder in a advanced analytics, ICU analytics corporation. So the objectives here over the next 25 minutes, my goal is to give you a brief history of acute care and big data and how the two have been intertwined. Give you some idea of where we've had successes, I think, in this domain, which is mostly in the retrospective data analysis, and then talk to you about the flaws in those analyses and understand just how difficult it is to do this work. And then we'll go into some of the challenges that we face in evidence-based medicine and how I think this technology is going to actually revolutionize both the research and the clinical enterprise over the next 10 to 15 years. So we all know we're in Atlanta. We at Emory right now run 4 hospitals. We have just under 2,000 hospital beds under our auspices as a health system, and then we have Grady, which has about another 1,000 beds. For those of you that know me, you know I'm from Detroit, which means that every single lecture I give must have some type of automotive metaphor that gets wrapped into it. And so as such, this right here is the first car radio. This was made by Motorola back in 1928. And this was a device that you could strap into your car that would then let you listen to the radio as you tooled about and did your daily business. And when you look at this, the car stereo remained unchanged, other than really perhaps the change to a CD player in sort of the mid-'80s, where you then went and had this sort of analog to digital conversion. But basically, all it did for 70 years was make noise in your car. That's all that really happened. This all changed in 2007 when Ford and Microsoft partnered and brought forward this, which was called Ford Sync, which actually introduced control of your car through your car stereo, which was, it also added some other nice features like you could order a pizza on your way home. There's progress for you, right? But you look just 10 years later, or even less than that, and you see in your Tesla that you now have essentially the key components controlling most of your automobile, or in the Model 3, all of the components controlling your automobile controlled through this device. And really, that was a huge change. And when you look at the future, if you happen to be in Palo Alto, you have the opportunity to get run over by this thing. And when you look at the inside of it, you can see that there's not even a steering wheel, but there's clearly a place that you could put some large screen that's going to allow you to interact. So the paradigm of driving will be totally changed, I think, within all of our lifetimes to an automotive fashion. But it took, and really the interface for that is through this, what was your car stereo. But it took 100 years for that evolution to occur. So now you're saying, what does this have to do with big data and acute care? And the answer to that is that big data is just the start. Amassing this data is the start of what we're going to accomplish. And it really started for us amassing this data in this country in 2009, when there was the HITECH Act, which was proposed, which was the Health Information Technology for Economic and Clinical Health Act, which when you look at it is how you get this HITECH logo. Now, when you look at this, there was a lot in this legislation that was designed as a stimulus during the Great Recession. When you look at that, what really happened with this was basically $40,000 plus was given to every hospital and every physician to install an electronic medical record in their office or in their hospital, with the threat that they would suffer consequences if they didn't do so. And with that, it was off to the races, and you can see starting in 2011, really, the number of implementations of this technology skyrocketed with massive aggregation of data. Estimated to be in the exabyte category now in terms of the amount of data that we have stored on patients in EMRs. And what this did really is it took us away from our patients and it let us treat everybody via computer. And I say that jokingly, but being an intensivist and anesthesiologist, I would say that we spend much more time looking at our computers than we do looking at our patients. And I think that we still practice the same way as we did when we were on paper. We just happen to get the data sent to us electronically. The problem is for us in using this data in anything other than caring for an individual patient is getting the data out. To look at this data for populations is challenging. And the reason for that is the EMRs that are predominantly produced by 3 vendors that exist today, Epic, Cerner are the #1 and #2 vendors, and then McKesson is a distant third. When you look at it, these systems were designed around individual patient care, and they actually aren't systems. They are multiple systems that are put together internally with common linkage. And there are sort of the big 4 components that exist in these things, which is scheduling, billing, laboratory information, and clinical documentation. Being an anesthesiologist, I'm going to say my special case is most important, so it gets up on the top line. But there's lots of other people that think they're special too, right? And there are actually people that are so special that they have their special case, and they even have their special vendor that provides a special piece of software for them. And integrating all of this together is a real challenge, to get all this so that you can use this data in aggregate to treat a population. So what most institutions do right now is they essentially take this data, they separate out all of these individual systems, and they start to import it into what's known as their clinical data warehouse. And if you start bringing this data in piece by piece, you're able to do things like reformat it, you're able to normalize the data, you can put it on different hardware, you can do background queries to develop higher speed analytics. Essentially, this is what you do, and this is what data warehouses do on a nightly basis. The problem with most data warehouses in healthcare right now is they're built for operations, they aren't built for research. And when you talk about operations, usually you're talking about financial operations. And so when you look at these databases, these data warehouses, what you actually have is something that looks like this in terms of the clinical data. And probably your most complete element of data is your billing data, right? So this is a problem for us in the academic domain that want to use this data to actually do stuff with it outside of the financial operations component. And this has introduced the idea of many institutions have built a research data warehouse, something like we just heard about, something that you might see in I2B2, similar to I2B2, where essentially you take all of that data that you can from a clinical environment, cram it into some type of repository, place a de-identification layer in between the two, and let investigators get access to that data. And this is a great step forward. It allows lots of investigation to occur. The problem with this is now that you have lots of data, the real issue is you have lots of bad data. Clinical data is filled with errors. And when you take a look at how bad the data is, this is some work we did looking at the development of acute lung injury and perioperative patients. You can see at the top there we started with nearly just over 82,000 cases. By the time you take out all the data that's bad, you're down to 50,000 cases to do your analysis. So we're throwing out a third of those cases, and we're throwing out a third of that population to do the analysis. And this was the recommended statistical approach from our statistical reviewer rather than doing imputation or other things that we could have done. So I would tell you that we need a standardized approach to this. And we're here in a public health building right now, and we can say that there's probably a fair bit of epidemiology that goes on. There's the Strobe guidelines that tells us how to report this data and tell us how to report the studies that we do. But it doesn't tell us how to do the study. And what we would really like to have, from my perspective, is something that gives us the clarity that we have. I'm not saying this isn't controversial, particularly when we start dealing with larger data sets, but it tells us what to do and it tells us where we currently draw the line. And we currently don't have that when we work with these really large data sets, particularly when they're very dirty, and how to do the analysis. Once you actually get through that bad data, you have the challenge of doing retrospective analyses. And when you look at this, this allows us to develop different types of correlations. This is that acute lung injury study. The thing that we start to find is that sicker people are different from healthy people. I know that's a shocking statement. And you wind up with things like this, with p-values that say these populations are different. And so there are various statistical methods to address this. I happen to like propensity matching, but there's lots of different ways that you can go ahead and match patients to develop what looks like a much more uniform population. And you can get something that gives you p-values between your populations that are essentially equivalent. And then you can go ahead and do your analysis and figure out what may actually be contributing factors to the development of X, Y, or Z disease. The problem is these statistical analyses are very challenging. Okay? And when you look at this, this is a propensity match study based on ECMO using actually 3 different matching algorithms, all of which look very similar. This is for H1N1 and extracorporeal membrane oxygenation, which happens to be another interest of mine. And when you look at this study, which is published in a fairly reputable journal, JAMA, you can see that this really brought to light the fact that maybe extracorporeal technology is something that we should consider using. This study was done in Britain. The French did a very similar study, and shockingly wound up with a very different answer. Okay? I don't think it's just because they're French. The interesting thing is if you use the British statistical techniques, this is the Kaplan-Meier survival curve you get. Both of these were vetted by statistical analyses at high-ranking journals. Yet we show very different outcomes based on these analyses. And I think this is very concerning. So we need standardized approaches to dealing with this retrospective data. This is a real challenge for us, I think, over the next 5 to 10 years. And I think as we start to see more and more large data set studies become published, we're going to need to deal with these things. The problem here really is no matter how good we are with our retrospective analyses, no matter how good we match, we're matching on known entities. And the entire idea behind clinical research is that you're assembling randomization of the unknown entities that are in the populations that you're studying. So causal inference is always going to be a real challenge for us. And I don't know how you address that in any other way right now other than the randomized control trial, which is really, for the future, going to remain probably the gold standard for us to develop our first test of what is truly causal in medicine. So I think large data sets are going to be very useful in acute care because acute care trials and informatics is going to be very useful because when you look at acute care trials, it's very difficult to enroll these patients. There are very high FTE requirements to run these trials because you're really dealing with people that are in your hospital 24/7, 365. And they, unfortunately, particularly in critical care, most of our interventions don't work. And when we find out they aren't working, we find out very late. We either have failure to enroll or it's after our second subset analysis that we say, our interim analysis that we say we need to bail on this. And so the question is, how can we improve research using informatics? And I think you can do that through what I'm going to call clinical decision support and point-of-care randomized trials. So when you look at clinical decision support, which we talked about this morning a little bit, you can see that you have this idea that you take some instance data on your patient, you take some domain knowledge about what you should do for that patient, you have some algorithms, you pump out a recommendation. There's nothing here that says that you can't say, I recommend that we randomize this patient to one of 2 modalities. And that's actually something that we've done. This is something where we looked at patients that were at risk for development of acute lung injury in the operating room, where they were randomized in real time to receiving either what was a recommendation for lung protective ventilation or no recommendation. And what we showed is you could actually change the way that people ventilated patients. This is very powerful, and you'll see why this is so important for us in the future. The problem with this is you need access to real-time data across your entire population of inpatients, and this is a real challenge to achieve. And the reason for this is that when you build your data warehouse and you bring all this data together into a single repository, you actually do that through something called an exchange, transfer, and load process. It's otherwise called the ETL process. And these processes are computationally intensive and sometimes involve taking down your production systems. As such, much of the time, these things are only done every 24 hours. And if you're in the acute care business, you're loading this data over, so that means your data is done either 6 to 30 hours old that's sitting in your repository. And when you're in the acute care business, you aren't really interested in what happened 24 hours ago. You're much more interested in what happened 24 seconds ago. And so that's the real dilemma. So how do you achieve this across a population? Because most of the systems right now that are produced are focused on that individual patient. They aren't focused on the 1,800 patients in your healthcare system. So what we've really proposed is revolutionary change. And the way that we're going to approach this at Emory is we're going to remove the data warehouse from this type of research and this type of analysis. And what we're going to move to is a real-time analytics engine, where we're going to bring all these components from our Cerner system at first into a single repository. We're going to use this using a set of technologies from Oracle, and it'll replicate our Cerner repository in real time. And it'll allow us to get everything out of that system and scan most of our medical records in a matter of seconds to minutes. Over time, this will probably expand to what we're going to call our real-time analytics platform, which will involve a whole bunch of other systems that we're going to drag this data in from, and to enable us to do more sophisticated analyses. And ultimately, what our hope is this is going to enable us to do what I'm going to term real-time precision medicine. Typically, we're thinking of precision medicine in the oncologic space of how can we target the right chemotherapeutic to the right tumor and the right patient. How can we get the right treatment to the right patient at the right time in the hospital, I think is our question. I think this will change things in both the research and clinical domains, but to start out in the research domain, I think what you're going to see is this. I think you're going to see these clinical decision support platform trials start to become a real phenomena that occurs inside hospitals. So for those of you that are familiar with the NIH PEDAL network, we are not part of that. We're looking forward to being part of it someday, and we're planning around that scenario. And when you look at PEDAL, this is a study of acute lung injury, patients that are at risk for it, and the goal with them is to enroll them very quickly. So our system will essentially be constantly scanning for patients that are at risk for ARDS. It will automatically screen them and then automatically signal an on-call screening coordinator. They'll get in touch with the physician, and hopefully we'll go ahead and get these patients enrolled relatively expediently. Now, if you're going to run a system historically screening someone 24/7, 365, that's a multi-FTE operation. Our plan is to do this all in 24 hours with a single FTE coordinator in 3 hospitals, dramatically reducing the cost of doing this type of care, of this type of study. I also think what you're going to see is the opportunity for us to move beyond doing the standard 2-group prospective clinical trial into what we're going to call platform trials, where you can essentially be running multiple therapies at once, looking for signal, which is going to be very useful and this is commonly used in the oncologic world right now, but I think we'll be able to do this internally in the acute care environment. And this will be very important because most of our trials fail. So where can we determine that we're starting to fail early? Where can we see signal that's going to generate a beneficial outcome early and start to push those therapies forward for further investigation? How is this going to affect clinical care? I think what we're going to really see is that we're going to need to change. Just the way that the car stereo didn't change listening to music in your car really for somewhere in the neighborhood of 70 years, we haven't changed the way medicine works. When you look at the way we did medicine 60 years ago in the time of Osler, all we did is basically move things to computer. The process is still the same right now. You show up, you pre-round, you examine patients, you round, you get asked some questions, you write some orders, you write some notes, you give maybe you get a lecture, you go back, you do some more rounds, you write some more notes, and then time goes where you did one more set of rounds, and then if you were lucky, you went home. Today, the only difference is due to work hours regulations, you know you're going home, right? That's the only difference. And as such, how do you change the paradigm for care delivery? And I think this technology is going to allow this to happen. Same is true in the anesthesia. This is the first anesthetic record by Cushing. What kills me was a neurosurgeon, but anyway, this was the first anesthetic record, all right? This is an anesthetic record today. All we did was the analog to digital conversion. We have done nothing else other than use electrons rather than pens to document the information. So I think if we're going to change the paradigm, what we will see is this. We will see a large paradigm shift in how we manage our patients. We're going to go to a population health mindset in hospitals because of this technology. You're going to see a team approach to management of patients. You're going to potentially see patients that get admitted to a hospital that never see a physician. I think you're also going to move into the realm of changes in decision support, in that you're going to get real-time notification for patients that are falling off trajectory. You're going to identify candidates for therapies that you never thought of as a physician. It's going to randomly appear to you in your clinical decision support in ways you never thought. And I think we're going to be expediting patient discharge based on statistical return to hospital models, much more so than we do right now, which is basically, I want to keep this patient another day because I think they might be at high risk for returning. None of this will happen, I fear, until we change reimbursement models. And with the state of healthcare today, I have no idea what's going to happen. But I would say with the ACA, assuming it stays intact, this is highly likely to occur. So for those of you that say this is never going to happen, I'll tell you this already has. So this is the electronic ICU at Emory right now. And this currently monitors about 145 ICU beds in Emory Healthcare and other hospitals around the state of Georgia. And when you look at this, these patients, these patients in each of these ICUs start out with much higher risks of mortality prior to the installation of this technology. And as you can see, it's essentially moved the risk of mortality during their hospitalization to essentially what's anticipated, what's expected. The OD ratio is basically 1. So the question for me really is, how do we take this technology that we've already proven can do this in the ICU, and how do we move this into the entire acute care environment? I think that'll be an interesting challenge for us over the next 5 to 10 years. So in conclusion, what I would tell you is this. First of all, getting data out of these systems is a real challenge. Once you're able to do that, you're faced with significant bad data that needs to be addressed. Once you have obtained that data and you address that, you have retrospective research that is fraught with statistical complications and is very challenging to interpret what the truth is from. I think it gives us a hint of what reality might be. And then I think we have the opportunity to do some very interesting research with this technology and really change the acute care paradigm using this technology, all of which I think will happen over the next decade. So with that, I'd like to say thank you.
Thank you, Jim. So that was very thoughtful. Do we have a very quick question from the audience? One up there. There's a microphone down here unless you want to shout. Okay, good. Yep, I can hear you.
So I have a very simple question. I think this is really fascinating. My only concern is that all this technology and all this new knowledge will be available to people who can afford it, which will actually increase the disparity in people who are uninsured or underinsured. Is there any work in the policy department that's going to help cover everybody with all of this?
Yeah, so I think in the acute care space, for better or worse, this has already happened. There are very few hospitals right now that are still on paper, primarily because of policy that's been already put into place. And even most private offices now have faced substantial penalties if they haven't installed some type of EMR. So I think that the concerns of this occurring in this country are low. Now, how do you do this in other countries? For example, a lot of Europe is nowhere close to this. Definitely the third world is nowhere close to this. This is very expensive. And unfortunately, to date, this has been pushed forward with very little evidence that any of this electronic medical record technology reduces costs or improves outcomes. But I look at this as a long game, and I think we've got a lot of time to go before we prove that there isn't benefit to it.
All right, thanks, Jim. So, quick announcement before I talk. Somebody lost a cell phone. It's got, you have to come and describe it to get it back. Specifically, you have to tell us which two people are on the front screen. So, and then it's yours, even if it's not. Okay. I don't know if you have to be one of those people. Okay, our next speaker is me. That's an easy intro. And I'm going to go super fast because I want to make sure our final speaker of this session gets enough time as well. This is fun because I love to talk about my own research, and this is not my own research. This is Shamim Namati's research. He's an assistant professor I recruited out of MIT and Harvard. He was my best PhD student, a superstar in the making, and he's been doing some wonderful work with myself and Tim Buckman. Tim Buckman is the guy in the middle, who is the director of critical care here at Emory, and is the reason that I came here. He recruited me here to work on the critical care data. And I think this work is sort of the fruition of many years of us planning and trying to get there. So I'm going to talk about this in a little bit of detail just because I think it's fun and it's a good example of what we can do with high volumes of data and a bit of machine learning. And then I'm going to try and talk about the think big part of it at the end if I get time. All right, so the reason that I wanted to talk about this is everybody must know the answer to this because it was on the previous slide. Who knocked out Muhammad Ali? Well, he suffered from Parkinson's for 30 years or more, as everybody knows, but he actually died of sepsis. For each hour without treatment or treatment for sepsis is delayed, or sepsis-related mortality increases by 8%. And so the question is, can we predict sepsis in advance? This is the question of Shamim Namati's K Award. He has a BD2K, Big Data to Knowledge K Award from the NIH, and he had a 5-year award for this, and he's 2 years in, and I think he's already cracked it. So I'm going to try and walk you through that. The reason he's not here talking about this today as well is he's presenting this work at a conference on critical care in Italy right now, so don't feel sorry for him. Let me take all the credit for it. So sepsis, why do we care about sepsis? About 27 million people develop sepsis every year. 19 million survive, but 8 million die. Also, if you're a survivor, you may face lifelong complications from sepsis. It's also one of the most, if not expensive, conditions that are treated in US hospitals. Was true in 2011 and is still true today. So it's estimated it costs us around $20 billion a year. And why do we particularly care in this region? Well, you've seen these maps over and over today. Where is the sepsis burden highest? Well, it's in the southeast. So that's one of the reasons that we're looking at this. I should have done this at the start, I suppose, and defined for you what sepsis is, but I've been deliberately avoiding that because sepsis is hard to define, as many people in the audience will attest. And in written documentation, it goes back to 1532 to Machiavelli, but fortunately we have a few more recent definitions of it that are a little bit more useful than Machiavelli's definition. Although sepsis is still more of a syndrome than an actual diagnosis, if you like, or a disease. Luckily, the most important thing when you're trying to do machine learning, actually, I should step back, is you need a very good definition of what your target is. There's no point in having a woolly definition of what you're trying to predict. So I think that's what's hampered sepsis prediction algorithms for a long time, as well as the lack of high-quality data. Luckily, though, very recently in 2016, a group got together, a group of experts, and redefined sepsis in a very practical way. And we're very lucky, and this is another good reason why I'm here right now, is that we have some of the people who define this in our audience here. Some of you might recognize the name at the bottom there. Greg's getting a shout out, but he's been too modest about it. We also have Craig Cooper-Smith. So we have some of the people who are helping us define these conditions. This has evolved over the last 10 years also from respiratory infection to sepsis to definitions of severe sepsis and septic shock. But now we actually have a pretty good definition that allows us to go into clinical data and objectively identify when sepsis has occurred. And it's a pretty simple definition. In the end, it becomes quite practical. It's suspicion of infection, so that means antibiotics were probably ordered, or at least a blood culture test was performed, and that something called the sepsis-related organ failure assessment score changed by more than 2 points. So it's important to know what this SOFA, or sequential organ failure assessment score, is. It's a classic lookup table, if you like, that has been produced in medicine over and over and over over the last few decades. And what's always surprising to me is, even though these numbers are essentially made up, are based on clinical expertise, but still nevertheless made up, they're extremely useful. The Glasgow Coma Scale, which is another one of these classic endpoint scales, where you have a grid of a score across the horizontal axis, and then you have a vertical axis of the measurements that you can make, and then you just simply give them points for being in certain ranges. You add them up, and it becomes extremely predictive. The Glasgow Coma Scale is still one of the most single predictive things in the intensive care unit that contributes towards mortality. There's one more thing that is more predictive, and I'll tell you about that later on, and why it's a mistake to measure that. That's a little teaser. So we have this SOFA, this sequential organ failure assessment score, and more recently the QSOFA. This is the quick SOFA, because obviously this is kind of difficult to calculate. You need a lot of measurements. You need to take blood. There's significant delays in calculating the SOFA, so it's not an extremely practical on-the-point assessment score. So there's the QSOFA, which is a reduced form of this, which goes down to basically 4 questions. And we'll loop back to why we're using that later. But for identifying the labels within our data, remember I said getting the labels is extremely important. And that's one of the things that hampers us in critical care, is actually translating the clinician's extremely good intuition into an actual label that we can use to say an event has occurred and make a prediction on that. So we're going to define the time that the SOFA score changes by more than 2 points, or at least 2 points in the last 6 hours. And we're also going to say, we're going to define a time when the suspicion of sepsis has occurred. In other words, whenever IV antibiotics have been administered, followed by a blood culture within 24 hours, or a blood culture has occurred, followed by IV antibiotics within 72 hours. These were defined with the use of experts to try and identify the absolute value, the absolute point where we can definitively say sepsis is occurring. And then sepsis occurs when both of these are fulfilled within a 24-hour window. Okay, so we defined sepsis. Now we have to go back through our data and find all our septic patients in these moments of sepsis. So we have all of these different pieces of information flowing off the bedside monitor. Jim earlier in the last talk alluded to the idea that we're collecting all of these bedside waveform data, this high-resolution data, as well as the clinical electronic medical record. And all of this is streaming off the bedside. We're collecting this and able to analyze it in real time. The key problem actually is relating all of these individual units made by different manufacturers to the data that's sitting in the EMR and pumping them out at the same time and fusing them all together in real time. And that's something that I'll wrap back to at the end. This all goes into a clinical database because this is a retrospective study initially. And then we sit down with experts that perform chart review to make sure that the things that we think we've detected are actually really septic patients. So when I show you the numbers on this, you're going to have to realize that we had clinicians go back and visually verify this in a chart review, which is going to be stunning when you realize the number of hours of labor that went into this. And then we have to do matching between all these streams of data. So all of these are siloed devices, and the way that you identify a patient within them is often different. It'd be nice if there was just one number that pertained to one human that was carried with them through every single device, but that's really a fiction in modern medicine. And so we do a lot of forensic analysis to try and tie these data together. So over the period that we analyzed, we have 31,000 Emory ICU admissions, accounting for roughly 60 terabytes of data on our server. 60 terabytes is mostly composed of this bedside waveform data. There's only about 20 gigabytes of electronic medical record within that. There's about a 10 to 20% sepsis rate depending on what patient population you're looking at. And as I said, we have these laboratory data, we have intermediate physiological data, and we have these high resolution waveform data. So our cohort, the only thing that you really have to look at here is that we had, after matching and throwing out everything that we distrusted, we had 27,000 patients, 25,000 of which were not septic, and 2,375 that were septic. And it's important to have that imbalance in your data because that reflects what you actually see in the ICU. It doesn't mean that you train your machine learning algorithm to learn that imbalance because you want to use it on an individual basis. So then we have to train our prediction model. So we have a series of things that we're measuring out of the electronic medical record as well as the bedside monitor, so the Glasgow Coma Scale, platelets, creatinine, arterial pH, temperature, etc. And these are measured every hour. We take an average, so we're just doing hour blocks here initially. And we're measuring over the last 4 hours as a window and then sliding it by 1 hour and trying to predict 4, 8, 10, and 12 hours ahead of time. So we start collecting data at T0, we start predicting at T equals 4 hours, and we slide it right by 1 hour and continue the prediction. So the 1 hour slide is really that, there's not that much happening in the world of sepsis over a period of an hour. So we have 1.25 million overlapping observation windows where less than 2% of the windows carry a sepsis label. So you have to think about that very carefully from a machine learning point of view. So what's the clever machine learning algorithm that Shamim decided to use on this? Well, turns out that a modified parametric Cox hazard model is state-of-the-art for this. And I'll show you afterwards and have a discussion afterwards with you about other machine learning approaches. But when your electronic medical record is quite sparse, it's very difficult to beat a simple logistic regression-like algorithm. I'm not saying logistic regression here because it's the wrong model to be using on censored data. And even Hosmer and Lemishow agree with that. So we can have a discussion about that later if you want. But the important thing is, what did we find? Well, Shamim's algorithm was able to predict sepsis with an AUC of 0.87, which is absolutely remarkable. So he set the sensitivity to be 0.85, and that gives you a specificity of 0.71. That's for identifying sepsis. If you want to identify actually the change in the SOFA score ahead of time, so you're predicting this change in the organ dysfunction, that's but not sepsis, which is even probably a better indicator of what's going on, you can get an AUC of 0.89. But what's more interesting is how far in advance can you predict this? So most people are trying to predict sepsis, a short window ahead of time, or they're trying to predict sepsis for days ahead of time, which doesn't make any sense. So what Shamim did was then look at this as a function of different prediction windows. And the one to look at here is the red line, actually. So this is 4 hours out. The results I was showing you there were for 1 hour out. This is for 4 hours out, 6 hours, 8 hours, and 12 hours. And you can see that he's still retaining an AUC of about 0.85, maybe 0.83 at a 12-hour prediction window. just to put that in context, this is the state of the art. The state of the art is off the bottom of the graph. So there was a publication quite recently actually called the Insight algorithm, where they took just the electronic medical record data, which is very important here. So all they're doing is using the same data as we're doing, except for the high resolution second by second heart rate and blood pressure and other bedside monitor data. And their AUC is 10 points lower, and they only measured it from 1 to 4 hours out as well. The other ones are just standards, so if you use the QSOFA or the Modified Early Warning Score or SIRS, then you're also down in the low 70s. So for me, that's quite remarkable. He's looked at this much further out in time and got much, much higher accuracies. Perhaps, as importantly, one of the nice things that you can do with this model is you can actually relate each variable back to its contribution to the prediction. So what we're doing here is ranking the actual variables in order of importance across the bottom axis, saying which variable is giving us the most amount of prediction in our model, essentially, what is contributing the most to our prediction of sepsis in this individual. On the middle plot, you can just see all the different variables over time, and you can see that with the exception of the heart rate, which is not very specific, to be honest, none of the variables are changing in any particular indicative fashion, and in fact, heart rate will go up and down with interventions and diurnal behavior. So there's nothing going on visually in the vital signs that will give us any predictive ability. Yet if we look at the risk scores on the top axis, the red line is just simply, does the patient have sepsis or not? So you can see that it flips at a point where the SOFA score, which is green, increases by 2 points. And also, somebody ordered antibiotics, and what we do is we pull that window forward and choose the earliest point in that hour window. And you can see that Shamoon's predictive algorithm output has gone above the risk score threshold at 0.5 several hours earlier. Each one of these is an hour, so it's predicting this about 10 hours out, and it's consistently predicting it as well. So if you're a clinician, you're looking at this and saying, this algorithm is telling me that this person's developing sepsis. This probability of sepsis is increasing hour on hour for several hours. Maybe I should be giving them prophylactic antibiotics and pressors and fluid at this point. But not just that, you can look down on the bottom axis and you can see what's contributing to that. So you can see that the ventilation, the respiratory rate, the temperature, the fact that they have a wound, the creatinine levels, all of these are telling you that there's something going wrong with the patient. And a good doctor can then reason what's going on with the individual and passing this and work out a physiological reasoning of why they should be administering antibiotics here. So I'm just going to briefly talk about why this is important in terms of outside the ICU as well. So we have 500,000 visits outside the ICU, and it's actually one of the biggest problems of somebody being admitted to the ICU. And where they came from is a significant predictor in that themselves. So when somebody comes from a nursing facility, that indicates that they are probably likely coming in with sepsis themselves. So actually rolling this back and monitoring these patients before they even get to hospital is extremely important. The big problem with that is that the data is low intensity and quite sparse. You don't have Glasgow Coma Scale and creatinine and all these different lab measurements on your patients in a nursing home. In fact, you don't have any measurements whatsoever. So one of the questions is, what can we do? Can we apply simple wearables like on-body or off-body sensors? So one of the things we're looking at in a CHF patient population actually is having them use essentially Apple Watches on steroids, or even stripped down Fitbit-like devices where we can poll the raw data and streaming that back to back-end servers so we can analyze this in real time. And one of the key things here is that sometimes we're using body-worn patches as well. These are beautiful epidermal patches made by MC10 that they give us to play around with. And the key here is that you can start to look at this high-resolution data and get almost as high a predictive power. So this is the very latest work, and we haven't even published this yet, but we're showing that you can get an AUC of about 0.882, 0.83, which is higher than you can do with the electronic medical record, just by looking at the joint distribution of heart rate and mean arterial pressure. So in other words, what we're doing is we're looking at the joint distribution. So you see in the middle plot at the bottom, there's a joint distribution of heart rate and blood pressure, and we partition it up and look for idealized states within there. You're basically creating a partition so that you end up with uniform states within it. And then you try and predict, or you try and look for where the patient is moving from one state to another. So they'll have a certain heart rate and a certain blood pressure value, and they'll move from that grid square to another grid square. And that's the physiological dynamics that the patient's experiencing. And heart rate and blood pressure are nice ones to pick because they basically multiply together to give you an estimate of cardiac output. So they're telling you something about the supply of oxygen to the organ systems. And we know that that is impaired in sepsis. So we expect to see some kind of pattern in this space. And what we do is we do a network analysis. We actually look at the frequency that it moves between these different grid squares and build a network. And this network actually looks completely different in control patients and septic patients. In control patients, you tend to go through the same set of grid squares and transition from one grid square to another in a very repetitive fashion. And that's because you're in homeostasis and you have fairly good auto-regulation and you're pretty well maintained. But everyone knows with sepsis, you get these transient hypotensive events and other uncontrolled cardiovascular events or semi-controlled cardiovascular events. So when you look at it in a network space, you find that they're dancing around with weaker links between different squares. And it turns out if you then extract features out of that and put that into a model, you can get a fairly high AUC. And that's just from 2 parameters. We're getting better AUCs out of that than people are getting with an entire electronic medical record for predicting sepsis, which I think is remarkable. We haven't published any of that, but that's something fun that just occurred in the last couple of weeks. And I think it's extremely important because it allows us to then extend what we're doing in the ICU out into into readmission domains, into home care settings, and reduce the amount of actual high burden data that we need to collect. All right, I'm going to wrap up really quick because I'm rapidly running out of time. We're going to do some retrospective studies on this. We've shown that we can reproduce this in external data sets. And the next thing to do is a prospective validation. We've built smart on-fire handlers where we can pull and push data in and out of the electronic medical record. And we can push this back in real time to an interface for the clinicians to use. So the next thing for us to do is actually provide this as a feedback system for them to make decisions. So that's what we're doing with Tim Buckman next. We're going to actually try and change the way that antibiotics and fluids and presses are administered in these patient populations to see if we can affect sepsis incidence and mortality in this patient population. I'm going to stop there, I think, because I run out of questions. I'm obliged to say something about the funding. This doesn't reflect the views of the government, which I'm very happy to say. Nothing I say reflects the views of the government. I'm sure I ran out of time there. So I'm going to, do we have a quick question? No, good. I'm going to be in the coffee area afterwards, so if you want to come and chat about this stuff, I'd love to. It's really some beautiful work that Shemin did. All right, so I want to introduce Rich, who you may see hobbling to the podium right now. He bravely came out. This is his first excursion out after having his operation on his foot, so we thank you for coming, Rich. Finish the intro. So Dr. Johnson is a postdoctoral fellow in the Department of Human Genetics working with Mike Zwick and Emory University School of Medicine. He received his PhD from Johns Hopkins and worked in the Institute of Genetic Medicine there. He's currently working on ways to improve the detection of genomic variants in large-scale sequencing data. So thanks, Rich.
Thank you very much. I think I'm good here. Take my crutch off. I'd like to thank the organizers for allowing me to talk about the good work we've been doing in the Department of Human Genetics. I'm on the bioinformatics team there, and for the most part, we are tasked with taking the vast numbers of human genomes that are being sequenced at the Emory sequencing core and analyzing them, figuring out what data is available there, doing the mapping, doing the calling, figuring out where the variants lie, etc. And when I joined the team, there was a backlog of, about 1,400 genomes that had been sequenced but hadn't been analyzed in any meaningful sense for the consortium that we're a part of, and probably another 500 after that. And so I'm going to tell you about how we built a system to analyze thousands of genomes very quickly using Amazon Web Services. So to start, a 30x genome is generally what we get back when we send an individual out to be sequenced. It's about 100 billion bases total of sequence that comes in the form of about 650 or 700 million paired end reads that are 150 bases long. Depending on the actual depth for each individual, that's something like 60 to 100 gigs per person. What do you do with all of that data? You try to map it to the reference genome. You want to figure out where each of these reads likely originated. And then once you have the mapping done, you look at the distribution of the nucleotides observed at every position, and you try to call variants. So that's mapping and calling. The fundamental computational challenges here are twofold, right? You have to have really excellent computational infrastructure, but you also have to be able to store tons and tons and tons of data, right? For small studies, you need terabytes of storage. For large studies, you get up into the petabyte range. And you have to deal with issues like moving data at this size takes time. If you want to move 100 gigs of data from one computer to another, it's going to take you about 42 minutes with a standard hard drive. And that doesn't even take into account any sort of network lag or slowdown or anything of that nature. So if you don't have your genomes in the right place where you can do analysis, everything is slowed down, everything grinds to a halt. So, can you do this yourself? Probably not. Your desktop computer has a CPU, maybe it has 8 cores in it, maybe you've got 500 gigs in a hard drive, maybe you've got a couple of terabytes if you're fancy. So you might be able to store a couple of these genomes, and you can probably map a single genome in a week or two on your desktop computer. That's nowhere near the throughput that anybody in this room is looking for. You can get up to 400 done in 8 to 20 years if you're really, really efficient at this. So the obvious solution is to transition to high-performance computing clusters, where you're sitting behind your desktop and logged into the cluster that has a whole bunch of different computational nodes. It's got a file server. It's got a whole bunch of shared hard drives. That's great in theory. And when we started this project, Emory had access to 2 of these. We have the in-house human genetics computing cluster system that is relatively lightweight computationally. It's got about 10 computational nodes, but it has a ton of storage. And then we also had access to the TARDIS system through Georgia Tech previously, which is no longer available. But TARDIS was low storage, high computation. The problem with mapping and calling algorithms is that for the most part, they are really, really awful to your hard drives. And BWA, which is the most common mapping program, is the worst. When BWA works, it reads a read into the program, figures out where it's going to go in the genome, and then outputs that information. So for every single one of those 650 or 700 million reads, there's a read-in step and a write step. That kills your hard drive, right? And we already know that disk reading and writing is incredibly slow relative to computation. So essentially when BWA works, it is just reading and writing. That is all it is doing. And disks and networks don't slow down linearly. They slow down exponentially, and you have timeouts and you lose your data. So doing that is not a great plan. And it's even worse if you're trying to do this in parallel, right? You can get away with running one BWA job. But when you're on a cluster with that shared set of hard drives, and you have 10 or 100 BWA jobs all reading and writing simultaneously, you're going to trash your hard drives. You just can't do that. So, in collaboration with Dave Cutler and Mike Zwick and other members of the bioinformatics team in human genetics, PE Mapper and PE Caller was created as a software package. We built our own pipeline, essentially, to do all of this. And it's designed to be much nicer to shared disk arrays. We do everything in memory. All the reads get read in once, all the mapping gets done, and then all the coordinates get outputted on the back end. So it behaves much nicer in a shared disk array environment. You can check out the details of PE Mapper and PE Caller we published in PNAS earlier this year. So, how does this work? How fast is it? On a 64-core workstation, we can map a genome in about 12 hours on average. And then once we have 100 genomes mapped, we can batch them up and do the calling for all 100 genomes in about 12 hours on a 64-core workstation. So it's pretty quick. How much data are we talking about? For the 22q11.2 data set, this is a microdeletion syndrome that we are part of an international consortium for. We have about 120 terabytes of data for about 1,500 individuals and their genomes. So when I came on board, this was the data set that we needed to be able to map and call. The size of the TARDIS disk array at the time was about 6 terabytes of usable space. So that made my life miserable. This was a big technical challenge. You can't have very much of this data, of these genomes, on the computer that can actually do the analysis. So the big challenge at the time was getting the data where we wanted it, when we needed it to be there. The way we did this was to move 20 genomes to Georgia Tech, start the analysis, and have it coming back. And so each of those steps, takes about a day. We had 3 different batches running in parallel, one going to tech, one coming back, one running. That's 20 genomes a day, and that was my entire life, right? That was full 100% effort just trying to map 20 genomes a day. That's not sustainable, right? You were talking thousands of genomes to do modern genomic studies. That's just not gonna work. And so we decided, hey, let's try Amazon. Amazon is theoretically infinitely scalable. You should be able to do all of this in one big batch. Emory had not yet figured out their contract situation with Amazon at the time, so we tried to contract with an outside Amazon reseller, and they just weren't prepared for us. And this is an ongoing trend. Every time Dave Cutler and I have attempted to use a new computer system, we warn them that we're going to break that system. And everybody always tells us, no, 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 it's fine. Our system is ready for this. And it never is. So the reseller definitely wasn't ready for us. We spent a couple of months trying to make it work. They kept claiming that they were going to fix their front end. Never really worked out. Fortunately, Dean Mike over here got his contracts squared away so that we were able to use Amazon ourselves. We've been one of the pilot studies for how to use AWS for big data in an academic computing center for about 10 months now. We told the Amazon guys the same thing, that we've broken every computer system that we've used. And they laughed. We're Amazon. We've got all the capacity in the world. You can't break our systems. And then I broke it almost daily for a while because they just weren't ready for us. But the good news is that once you figure out a couple of technical hurdles, you can do almost literally anything you need to do on a computer with Amazon. The bad news is you might have to build it from scratch, but you can come see me and I can help you do that. There are some pre-existing solutions on Amazon. Some very popular software packages have an Amazon machine image that already exists that you can just pick up. Some of them are free and open source. Some of them you have to pay a little bit for. But for the most part, you can probably do it better yourself. The real good news is that it's not that complicated. There are a ton of settings, there's tons of parameters, but the vast majority of them deal with security for internet-facing computers, where you have to make sure that your data is secured. When all you're doing is analysis in a contained environment that has no internet access, you don't have to worry about so much of this stuff. So, the Amazon Basics, for those of you who have not yet started to use it, S3 is Amazon File Storage. It is a giant unlimited storage cloud drive that you pay for by the gigabyte. If you upload your data to S3, it's available for use on Amazon computers, and you have a data backup already, which is super useful, because I bet that there are some people in this room who do not have good data backups set up at the moment. You should really fix that. You can completely avoid S3 if you don't want to pay data storage charges. It is possible. You can move from Emory computers to Amazon computers directly. They've developed a direct connect pipe now. It's very fast. But if you try to scale this up to doing more than 10 or 20 analysis at a time, you're probably going to run into a bottleneck as you try to scale things up. The other piece of Amazon that you need to be aware of is EC2. That's the rental computer market. You rent what computers you need when you need them. You can rent tiny machines with few resources up to the super heavy-duty 3.8x large machines that are 32 core, 244 gigs of RAM, 640 gigs of solid-state drive, up to even bigger machines with higher memory or more cores for very specific uses. You can really get anything that you might need in the rental market. The simple workflow for how this works is you create your bucket on S3, you put your data there, you launch an EC2 instance, download your data and a software package from S3 to your computer, run the software, upload the results. It looks something like this. With my very pretty PowerPoint drawings here, the data goes into your bucket, you put data and software on an instance, you do your analysis, and then you've got results. And you can put those back in your S3 bucket to do further analysis on Amazon, or you can bring them home to Emory if you have, your pipeline set up here to do your downstream analysis. Whatever works best for you. So that's all fine and well if you want to do one round of analysis, you want to do one genome. Maybe even 10 or 20, depending on how much you dislike your programmer, postdoc, graduate student, whomever is in charge of this. But what happens when you have thousands of genomes that you need to do? Amazon can handle it really, really well, actually. You create an Amazon machine image that has your software on it. So every time you start up a new computer, you have the exact software that you want. And then they have a template-based launching system called CloudFormation. So from the Emory Human Genetics computational cluster, I can sit there, I'm in a directory that has all of these genomes in it. I can loop over every genome in that directory, have it spin up an EC2 instance, pass it one parameter, which is the name of the individual, and then the EC2 instance spins up. It has the mapping software on it. It knows to download that specific individual genome from S3. It maps. It sends the data back. The only real limitation here is how much money you have and how many Emory IP addresses you can get access to. So this is what I just told you about. Built the mapper image, spin it up, launch over several hundred genomes, and each time it spins up a new computer, it downloads the correct genome, it does the mapping, and then it sends your data back to S3. You can, if you're very comfortable with this, you can configure it such that as soon as the mapping process is done, that computer kills itself so that you're no longer paying for it. It limits your overrun charges, and you have all of your data back at S3. You have to do some serious troubleshooting along the way to get this set up so that you don't lose your data, but once you have it working, this works very nicely. And it's essentially all automated for hundreds or thousands of genome mapping jobs. Once that's done, you use PE caller, you spin up an instance there that is going to call about 100 genomes at a time. That's the optimal size for us. And here, there's a little bit more work. You have to SSH into your instance and grab a file that essentially defines the batch that you want to call. And then the instance downloads all of those mapping results, runs the caller, and sends the results back to S3. So this one's a little bit more labor intensive, but because we've shrunk our scale down by 100-fold, that's tolerable. So how does it work for us? When I started on the local machines, I could do 2 genomes a day. Moving all the data back and forth to Georgia Tech, I could do 20 genomes a day. Now, on Amazon, we can do 200 genomes a day, and that is infinitely scalable if I could get more resources from Amazon or more IP addresses from Emory. Amazon really wants to make sure that you don't run up, say, a $100,000 bill without knowing it or being able to pay it. So they limit the number of resources you're allowed to access to start with, and you have to beg and cajole and tell them that you really, 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 really mean it, that you want all of these resources in order to get access. But for me, to meet a recent deadline, which happened to be flying to Japan for my honeymoon, so I really, really wanted to meet it, I was able to map and call more than 1,000 genomes in less than a week, which was really, really impressive throughput. So what's my take-home message for you guys? You should use Amazon, not just because they've gotten rid of TARDIS, and so there really isn't a great on-campus cluster environment. It's not scary. It's a little different, right? You can't physically see the computers. They're not always there when you want them. You have to spin up what you need, but you can get used to it. It's super flexible, right? You don't have to use it the way that I do it. If you really like a cluster environment, you can rent one big machine, put SunGrid Engine on it, and run it like a cluster. You can run small, always-on, internet-facing instances to do surveys in the Grady emergency room or something along those lines. You can have a live database that indexes everything that goes into your bucket to make it searchable. Anything you can think of, we can figure out a way to architect for you using Amazon. The real question is, what do you need it to do? And as of yesterday, I'm going to be the new core director for the Emory Computational Core, working with Mike Zwick and Viren Patel. And so if you want to start or need help moving forward, come talk to me, and I can get you started on everything through the computational core. You can use your speed type. You don't need a credit card. We can get you an account. Whatever you need to do with Amazon, come see me, and we can get you started. So I'd like to thank everybody in the Human Genetics Department on the Bioinformatics team. Dave Cutler wrote the vast majority of PE Mapper and PE Caller. Mike Zwick, Mike Epstein, Steve, Jen, Alex. The Emory LITS team has been very helpful with this pilot program. The computational core helps with a lot of this stuff. And we have a really good Amazon support person on campus named Kevin Niekirk who can help you with a lot of this stuff when it gets over my head. So thank you, and I'll take any questions.
Thanks, Rich. That was wonderful. I can't emphasize enough how much we need to be moving to the cloud. We're moving a lot of our stuff, especially mHealth monitoring, to the cloud at the moment, and we'll be talking with our group more and more with yours, I'm very sure.
Good.
Does anybody have any questions? I was going to ask, sorry, go ahead.
So that's actually a really good question.
Sorry, did everybody hear that?
The question was about HIPAA compliance. Emory and Amazon are working to create one means of using AWS that is going to be HIPAA compliant. I'm actually not sure if they are finished with that, but it is definitely in the works. The stuff that we have done to this point has not had any personal health information, so we haven't had to worry about that, but I'm well aware that lots of you will worry about that, and that is in the works.
So we pre-certified 20 of the HIPAA compliance services from Amazon, and I've tested that. It's still not all together in a packaged production offering, but that's a priority for us to get done in the next few months. So we're real close to that.
I know that Amazon themselves are announcing services one by one that are HIPAA compliant, like their messaging service. Quicker than we'd like. Yeah. Do we have any other questions before we go to the break? Did we have anybody who lost the iPhone? Any claims? No, still? Need more clues about who's on the image? It has a cracked face, but I don't think that narrows it down, does it? So, I use Android, it's true. All right, well, let's thank our speaker again, and let's go to the break. We'll be back at 3.